All right. Hello, everyone, and welcome to Speaking in Layman's Terms, recent developments in CF lung infection causes, diagnostics, and treatment. My name is Haley, and I have cystic fibrosis. Currently, I'm working in clinical research, not in CF, but with retinal diseases. I will be moderating this session this evening, and I'll be introducing our other speakers in just a moment. This session is also being recorded and will be available to all registrants after the event on the CF Foundation YouTube channel. You'll be notified by email when the session recordings are available. Before we get started with the session, I want to go over a few items related to the technology and how we can all interact. First, closed captioning is available. You can turn them on by moving your mouse over the video feed and clicking the CC icon that will pop up at the bottom of the screen. Under the Stage tab on the right side of your screen, you'll notice the chat for everyone who is in this session. If you're in the Event tab chat, that is for the full event and not specific to this session. So be sure you're in the correct chat to engage with the others in this session. We will be taking audience questions during the session. We encourage you to submit your questions at any time into the Q&A box. You can find the Q&A by making sure you are in the Stage tab on the right side of your screen, then select Q&A. We will do our best to answer as many questions as possible. You can also like questions submitted in the Q&A by others, which will help us prioritize based on popularity. Make sure you use the Q&A box to submit questions, not the group chat where questions may be missed. We won't be able to answer questions about individual diagnoses or treatment plans, and we encourage you to use the information you learned today to have conversations with your care team. There will also be a few polling questions from us panelists, which you'll be prompted to answer throughout the session. These polling questions will help us get an idea of what everyone is excited to learn about today. Polls can be found on the right side of your screen next to the Q&A chat. We will let you know when the polling questions become available. If you have any technology problems during the session, go to the expo area and visit the help desk. CF Foundation IT support are there to help you if you are having any trouble during the event. We have three amazing speakers joining us today. First up, Dr. Luke Hoffman will cover a brief background on infections. Then Tiffany Burnett from the Cystic Fibrosis Foundation will give us an update on the Infection Research Initiative. Dr. Hoffman will then walk us through updates from recent workshops on detecting and diagnosing infections. And finally, Dr. Gina Hong will give us some great insight into how infection research is responding to changes in patients' ability to cough up sputum. So most of us here in this session today have probably been impacted in some way by infections, whether it's been yourself or a loved one. Well, I've had my fair share of pathogens, trust me. Most of my issues have been caused by my friend MRSA, who I have right here today. During my time in college, I did deal with a lot more frequent and worsening infections. And it kind of got to a point where I was dealing, with a lot of day-to-day struggles with pain, low-grade fevers, whether or not I was actually dealing with an active exacerbation or not. The scariest part to me, however, was not those specific issues. It was the shrinking list of usable antibiotics I had at the time. And I remember specifically sitting in one of my college classes one day after I had been sick, and a friend came up and asked me how I was feeling, and I just completely broke down because I couldn't really possibly describe to her what it was like, living with a multi-resistant infection as a 21-year-old college student. Thankfully for me, though, Trikafta did get FDA approved for me, like right at the right time before I lost a bunch of my lung function. And of course, it's not an option for everyone. And even if it is an option for you, it doesn't fully resolve, the infections that we're dealing with. I still culture MRSA. And while I don't have those day-to-day issues, I'm still low on antibiotics on my list. Hence why the focus for our presentation today is so important. So with all that being said, I will turn it over to Dr. Hoffman for his background on infections.
Haley, thank you very much. That was the perfect introduction. Personal story is always the best way to show everyone how relevant these issues are. It's an honor to be here, and I'm looking forward to your questions. I thought what I would do to start off is explain how we think CF lungs get infected in the first place. Next slide, please. And yes, Yes, well, I'm going to give some background on infection. First, I wanted to explain that I do consult on behalf of the CF Foundation for companies and researchers who are developing new therapies. This is a, a role I play on behalf of the CF Foundation. Of course, this is a nonprofit venture. Next slide. So in reviewing how CF lungs can get infected and how many of your infections may have developed, I think it's really helpful to review how lungs stay clean in general, including CF lungs, and what goes wrong in the case of people with CF. All of us, whether we have CF or not, inhale tens of thousands of liters of air a day. And we've heard a lot about this over the past couple of years, but that air has a lot of things suspended in it. That includes bacteria from the environment, as well as viruses, fungi, some other things, other particles. And in general, most of those particles that we inhale deposit or are filtered out by the nose and the mouth, which of course have their own bacteria and other microbes as well. So that air is mostly cleaned, but but some of the microbes make it past those initial filters. And then those columns of air, which now have picked up new microbes from the mouth and the nose, continue down through the windpipe, that's a trachea in the middle, and then successively smaller and smaller airways as you get to the lungs. So by the time the air gets to the lungs itself, the little air sacs you see in pink, they generally are very few or no microbes. Most of them have deposited on those airways, and each of those airways, regardless of its size, secretes a very thin layer of mucus. Its job, if you want to think of it that way, as a gel, is just to collect all and trap all the stuff that we inhale. And then we can move that gel out and all the microbes contained in it through a couple of different mechanisms. There are tiny little projections on our airway cells called cilia that actually beat actively, and they only beat up. So it sort of acts as a little escalator to move your mucus up and out. You then swallow it without thinking about it, or occasionally there's enough that you think to cough it out or spit it out. Cough is pretty effective as well. And then whatever stays behind, our immune system generally mops up. And the problem in CF, to make a long story short or oversimplify, is that all three of these mechanisms are impaired. Next slide, please. So this is diagrammed a little bit carefully or a little bit effectively right here. In the upper right-hand corner, that's supposed to be a cutaway of a healthy human airway. Keep in mind that the diameter of that airway is about 1 millimeter. So this has been greatly blown up. And there's this very helpful arrow in the upper right-hand corner that points out that thin layer of mucus, if you could see it. And then the bottom, that's supposed to be a cutaway of a similar airway in someone with CF. Because due to CF itself, there's an imbalance in fluid and salt secretion in the airways, and that leads to very sticky secretions. Mucus just builds up in those airways, including all of the stuff that it's trapped, all the microbes, etc. And that leads to repeated cycles of infection and inflammation with those bugs that have set up shop in that mucus, and that ultimately leads to inflammation and scarring of the airways. Next slide, please. So with that in mind, the way I apologize. I actually have a cough and I'm trying to mute myself in between. I thought it would endear you to me if I coughed during this entire thing. The way that we diagnose these infections and choose treatments for them is by taking the secretions from CF patients and then culturing them in the laboratory. So, for example, we take sputum or swabs. If people can't produce sputum, that's usually their throat. Or we can use a bronchoscope to go in and wash a little bit, a lavage. We then use those samples to inoculate laboratory growth media. And here you see a Petri dish. You can also do it in liquid. And then we let the bacteria grow up on those, but we've chosen those media to select out the bugs we think are the most important ones and against anything we think is a contamination. We then take a few isolates of those bacteria or fungi, and we reculture them. What you see on the bottom is actually a Petri dish that's been swabbed with MRSA, which we heard about from Haley. And so there should be a lawn of MRSA growing on it. And then those white strips you see are actually impregnated with different antibiotics. So it shows you where the darker zones of clearing are, that this particular isolate is susceptible to all of these 6 different antibiotics. So based on these results, we diagnose these infections from from people with CF, from their secretions, and we choose antibiotics to treat them if we've decided that they need antibiotics. Next slide, please. And this is the depiction that we get from those methods of CF infections, at least during 1 year. This is a slide put out by the US CF Foundation every year. These are the most recent data available. This is from 2020. And it shows you the proportion of patients on the y-axis with CF in the United States who had their respiratory cultures positive for these 6 traditional pathogens, and they're listed on the bottom. The x-axis shows you that these data are broken down by age. So young children are in the bottom left hand, people older than 45 in the bottom right hand. And so you can sort of get a feel for how these infections tend to start in young children on the left and then evolve as people get older. And I'll just point out a couple of points because we'll come back to these pathogens. In green, this is Staphylococcus aureus. That's the most common organism cultured from people with CF, and you can see it's particularly common in children, and it becomes less common in older people. And then in blue, that's Pseudomonas aeruginosa, which many of you may know. It is uncommon in children, but still detected, and then, pardon, becomes more common as people get older. Next slide, please. And this slide shows you those data in a slightly different way. These are, instead of showing you how infections change as people get older, this shows you how these infections have changed for all people with CF over the past 20 years or 15 and a half years. And what you see on the x-axis is year from 1993 until 2019 on the right. What you can see is that Pseudomonas aeruginosa in blue has actually become much less common in people with CF. It used to be the most commonly detected organism. Now it's detected in fewer than 50% of people with CF, but it's still there. Staphylococcus, on the other hand, has become much more common. And then there's a subtype of Staphylococcus called methicillin-resistant Staph aureus. We just heard about that. It's a particularly antibiotic-resistant version, and it is also increased in prevalence. Okay, next slide, please. This is just a list of the cast of characters, or the rogues gallery, if you want to call it that. You might have heard these names before. There's Staphylococcus aureus, which many of us call staph, and its subtype MRSA, which I just mentioned. There are Haemophilus species. There's Pseudomonas aeruginosa, also called pseudo. There's Burkholderia species. Stenotrophomonas multifida, which many of us called steno. Non-tuberculous mycobacteria, or NTM. And there are a variety of fungi as well. We'll hear about some of these from Gina in a minute. And you may have heard some other names as well. Happy to talk about those if people are interested. Next slide, please. I just wanted to point out that we're just now starting to understand how these infections change when people start on modulators. They clearly do change. We also know that lung transplant changes, but doesn't completely eliminate the risk of having a lung infection. People with transplanted lungs can still get infected. And there have been a lot of advances in infection treatment in recent decades, not just antibiotics, but other kinds of treatments. And there are a lot more in the works, some of which we'll hear about today. Next slide. In addition, as we're going to talk about today, fewer people are coughing up sputum. And this is a good thing, very good thing. It means people are getting better. But it does make things a little complicated because this is the sample type that we prefer in diagnosing and understanding people's lower respiratory infections. And so now a lot of people are working on trying to understand how we're going to diagnose people's infections as sputum becomes less common. How do we not just diagnose them, but how do we choose treatments that we know are going to make people better?
Yeah, all right. Thank you so much, Dr. Hoffman, for that background. Next up will be Tiffany Burnett, and she'll be talking about Infection Research Initiative Update. Tiffany, I think you're muted. Apologies, everyone. Tiffany's working on unmuting herself. I think in the meantime, we'll have Dr. Hoffman jump back on and talk about the recent detection and diagnostic workshops that he attended.
Oh no, you get to call me Luke. I like first name.
Excellent.
Yeah, while Tiffany works on that, why don't we go ahead? This is a little out of order. Some of the details that I'm going to talk about will refer to some things that you will hear about from Tiffany in a minute. But I wanted to describe, following up on the theme that I just mentioned, a set of workshops that I was fortunate to lead on behalf of the CF Foundation with my colleague Lindsay Caverly, who's at the University of Michigan. And the whole rationale for these workshops was that people are producing less sputum. We wanted to take this opportunity to review what we're going to do in the future. But it also gave us an opportunity to really ask questions that we'd never answered appropriately in the past about how samples that people with CF produce predict or don't predict their clinical course and which treatments are going to work for them. Next slide, please. By the way, these were called the detection and diagnosis workshops. We did use a logo for Dungeons and Dragons just to cement the fact that we're very nerdy and proud of it. I also felt like I had to explain to anybody who asked why we were designing a set of workshops about sputum. I think people on this call probably get it, but my children didn't. And we needed to explain that sputum is very important. Again, this is the sample type that we use to diagnose people's infections and to direct our therapy. And it's been reported to be decreasing, particularly with modulators, but this started happening even before modulators. Now I'm listing these three figures on the right, list three different places. The PROMISE observational study, Community Voice, which is a series of questionnaires you're going to hear about in a minute from Gina, and then the CF Patient Registry, as I described, which is just it's a listing of data from the CF Foundation. All three of these have really shown us that sputum production has become less common, and it came before modulators started. So it's great news. It means people are getting better. But it does raise important questions about how we're going to monitor for infections. And also, it gives us a great opportunity to figure out if there are better ways to do this and pick antibiotics that don't require sputum. And as I mentioned, this also gave us an opportunity to rethink really important questions about how we diagnose infections and how we choose treatments that we hadn't really asked accurately before. And so to this end, we've now had two of three virtual workshops. The first was just a planning workshop in 2021. We had our first full workshop in October 2021, and we plan to have a third, pardon me. But we're hoping to do that in person once my cough stops. And so we'll wait to do that probably sometime after the spring. Next slide, please. Our overall goals are to review how we currently study the CF respiratory tract. And we noted that we use these samples not just to diagnose infections, but to study them, and also to study inflammation and to study the chemistry of mucus and how it changes with different treatments, how sticky it is. We also wanted to talk about how things have changed in terms of sputum production as treatments have changed, including modulators, but even before that, to discuss what options we have going forward, knowing this is happening. And we said explicitly that our focus right now is on research. We want to help to define this issue and what our options are through research first, but ultimately our ultimate goal is to, of course, change clinical treatment to figure out what best is going to make patients better and what is making them sick in the first place. Next. Our key questions were, how do we currently sample the respiratory tract of our patients? How do we use and interpret those tests? Is that the best way? How have our options changed in recent years, and how do we expect them to change further in the future? What approaches are there for sampling the respiratory tract right now? How useful is each approach for predicting outcomes and choosing treatment, or what don't we know? Are there approaches that we can use to choosing treatments that don't require sampling the respiratory tract, which is something that people actually sometimes do already? But most importantly, as on the bottom, what do we need in terms of research to develop, evaluate, or validate new approaches. Next slide, please. And so this was the agenda of our workshop so far. We've reviewed first common use of sputum, what we currently use it for or have in the past, both in terms of clinical care and research. We then talked about all the traditional methods for sampling the respiratory tract that we've used in the past, how we use those to choose antibiotics. And those diagrams you see in the upper right-hand corner are showing you the 3 different sample types. Many of you have probably seen these. They're the throat swabs, sputum, and bronchoscopy or lavage. We talked about what we can learn from people who have diseases other than CF. And then finally, we talked about some of the promising methods in development right now, such as chemicals in exhaled breath as biomarkers of infection in the lung, blood, urine, and other biological samples, and some other laboratory developments that are promising. Next slide, please. Ultimately, we brought together a really engaged and energetic group of specialists, clinicians, scientists, industry folks, representatives from the foundation, and some really clever engineers and chemists who are developing new and non-invasive biomarkers. We generally agreed about what the problems are, if there are problems, and what we need to do. We also agreed that the time is right to really review whether we were doing things really appropriately in the first place in terms of how often, how we were sampling people's respiratory tracts, how we use them in terms of testing. And in this case, we said out loud, we want to make sure that we are always asking whether the test really accurately predicts whether somebody is getting sicker or is sick, and also whether a treatment that we choose based on that test makes them better. Next slide, please. We all agreed that that we've not yet finished, that we need a third meeting. We ranked our recommendations according to how quickly we need to act. And the goal at this point is to direct research through new funding for research projects and grants, public recommendations for what the priorities for those studies should be. But most importantly, we brought researchers in the foundation together and agreed that we need to respond to these changes to figure out how best to diagnose infections and choose treatments, and to raise awareness of the community and of the importance of finding better diagnostics for infections in this new era. Next slide, please. And I think that's it. So thank you.
All right, so up next we have Tiffany Burnett, all ready to go, mic unmuted.
Yes, we're ready this time. Thank you. Thanks, Haley, and thanks, Luke. And thanks, everyone, for your patience in terms of the technical difficulties. But it is a pleasure to be here this evening with you all and to share some updates as it relates to the infection research space. Again, my name is Tiffany Burnett, and I'm a senior director here at the foundation. And as part of my role, I oversee the Infection Research Initiative, and I oversee the industry portfolio for infection. Next slide, please. As a reminder for some and an introduction for others, the IRI launched in 2019 with the 5-year, $100 million commitment to improve detection, diagnosis, treatment, and outcomes of CF-related infections. This initiative is led by a committee of CF experts, opinion leaders, and community members, and CF staffers. Great progress has been made to date with our infection research initiative. In fact, the end of 2021 was very busy. We were able to actually achieve our $100 million milestone, funding over $100 million in research at the end of 2021. We also held our 3rd annual steering committee meeting. Also, as part of the IRI, we look to prioritize and align across basic and clinical research from an industry and a basic research perspective. And as Luke mentioned, we also look to align and focus on pathogens that are of most challenges to CF. If you note on the microscope, we have also 6 areas of focus, and we really do align around those 6 areas of focus as well. And in addition to feedback we got during the steering committee meeting. We also got some great feedback from our community members that make up our steering committee. And we will also be working on enhanced communications, updating our website. So again, this is the focus of our IRI. Next slide. As I mentioned, the initiative helps us to focus and prioritize efforts. A large amount of our funding and resources are in the following priority areas. Understanding CF microorganisms. And this is the area where most of our basic research happens. So all of our RRT research and training grants really comprise of understanding CF microorganisms. As Luke talked about, we are very dedicated to improving detection and diagnoses. And he shared with you all of the important happenings there in 20 and 21. You know, Luke and I and Lindsay Caverly will again partner this year and hold that third workshop. And again, prioritize the work that the foundation will do on behalf of detection and diagnoses. And the last area of focus that we really spend a lot of time in is optimizing current treatments. Next slide. Now, here's another way that we kind of evaluate and track research priorities by pathogen. In 2019, fungal became a very important initiative and a very important focus area for us here at the foundation. And Gina, in a bit, will tell you a little bit more about what we have going on in that area. Also, if you take a look, we had some uptake in our viral spend, and that was really based on an RFA for SARS-CoV-2, and we should be seeing some of that research pan out this year and some of the findings in that research. And we also spent a bit of time and a bit of resources on a multi-organism approach, if you will. So again, these are compounds or projects that cover multi-pathogens, and we'll talk a little bit more about that when we start talking about the industry a bit. Next slide, please. So before jumping into the industry, I just want to recap. To date, the foundation has committed over $100 million to new research across academia and industry. We've more than doubled the number of funding academic programs, totaling over 200 projects, and we have more than 24 active programs in our industry portfolio. So we've made a lot of strides, and we won't be putting the brakes on any of this. We just wanted to share how happy we were to have reached that commitment almost 2 years ahead of schedule. Next slide. So now we'll transition a little bit to the industry portfolio and new therapeutics, as Luke talked about, is where our ultimate goal for infection is to give patients other options in terms of fighting those infections that become resistant. I want to just highlight here that our portfolio is very fluid at times because drug development companies make decisions based on scientific data as well as business. So sometimes, you know, it's out of our control how projects move forward. But my colleagues and I are very busy talking to multiple companies across multiple modalities and phases of a development in order to bring the best science forward. We actually had over 100 company calls in 2021, and we executed over 7 new contracts, and we're currently in active discussions with many other companies as we speak. Next slide. So just a little bit about our portfolio and some of the things that make us excited. As I mentioned, we do really make a concerted effort to diversify our portfolio from a modality perspective as well as the stage of development. So if you can see here, we have multiple programs in preclinical and also in the development stage. When we bring in opportunities, we evaluate them based on what's going to be best for people with CF, but also really just trying to interrogate the newest science. So when we speak of novel compounds or novel mechanisms of actions, companies like Spesis, who has a compound called moripavidine, which is a peptide, a protein. And basically, we get excited about novel compounds because they have an opportunity to potentially fight drug-resistant strains. they have an opportunity to potentially offer broader coverage to multi-pathogens. And while there's more risk, there could be more gain and more help for people with resistant infections. Another area that we really do focus on are non-traditional antibiotic agents, which are things like nitric oxide, from Beyond Air, which are actually, they actually fight the underlying symptoms of infection. So it would be in the area of biofilm eradication. So again, by doing that, it would allow the other treatments that folks are taking to act more effectively. Another non-traditional program would be our inhaled gallium citrate program, and also our phage programs. And lastly, another area of concentration that we, focus on in our portfolio are approved drugs that we are redesigning for potentially better benefits. So programs like our oral amikacin program through Matinas. So again, very, very active, over 24 programs. We actually do have a program from our lung transplant initiative and fungal. So we're really excited about that. And we now do have a phase 3 program that we're funding for inhaled colophon. So again, lots of exciting things going on within our portfolio. Next slide. So just to round things up, we're really excited to continue with the aggressive approach beyond that $100 million, and we're not going to ease up. But in terms of our focus for this year, as Luke mentioned, detection and diagnosis is high on the list. We'll also be evaluating the impact of highly effective modulators through some real world studies that we have ongoing. Our fungal space is heating up, and Gina's going to bring us up to speed on that very shortly. Again, our industry awards will continue to progress. Our research grant reviews are underway for 2022 in both the basic research and the clinical areas. From an advocacy perspective, we just had our 15th annual March on the Hill, so our advocacy efforts will certainly continue. And as I mentioned, as with feedback from the community during our last steering committee, we will continue to push our communications, update our websites, update our white papers, and make sure that we're sharing as much as we can about our progress in this space. And with that, I will pass it back over to Haley, and Gina's going to share some additional information with us.
Great. Thank you so much, Tiffany, for that fantastic update. That was really, really insightful. Next up, we have Dr. Gina Hong, and she's going to talk about changes in sputum in the era of modulators.
Thanks, Haley. Yeah, Tiffany, that was such a great overview of all that the Foundation is doing specifically for infection research. It's a really exciting time for all of us, both people with CF and caregivers of CF, and also us clinicians and researchers on this side. So I'm going to be going and talking a little bit more about how infection researchers are responding to the changes in sputum expectoration or coughing up sputum, as Luke and or Dr. Hoffman and Tiffany have outlined. Next slide. So I just have some grant funding from the NIH and the CFF just to mention. Next slide. So really, we've kind of already discussed this already, but in order to really get a good understanding of what is going on currently when it comes to sputum production and what people with CF are dealing with, and the best way to do so is really to ask you all, people with CF, caregivers of children with CF. So we utilized community voice really to get those answers. And so the Cystic Fibrosis Foundation and the Therapeutics Development Network, that's the clinical trials network, conducted an electronic survey to better understand what the landscape looks like. So what does sputum production look like in the CF community? This was conducted in June in 2021. Some of the people on this call actually might have been respondents to this, and some of you all may have heard some of these results, but if you haven't, I'm really happy to share some of those with you today. Next slide. And so the survey results were 168 respondents. That just means that 168 people filled it out. And this is just an overview of who those individuals were. So you could see on that first graph that it's mostly adults with CF who responded, but about a third of people who responded were parents of children with CF. And when it comes to lung function, which we often use as like a marker of how well you're doing with your CF, but you could see that there was a range of lung function, about a little bit over a third with completely normal lung function, but also individuals who filled out the survey had severe airflow obstruction, and that under 40%. And then finally, when asked if they were on any modulators, respondents who filled the survey out were mostly on Trikafta, which is not surprising since it's more widely available based on genotype. And you could see that 60% of people who filled out the survey are on Trikafta, but keep in mind about a quarter are not taking any modulator. So this kind of gives you the landscape. Next slide. And the key question was, is there sputum that is being produced? So this was an answer to a question of, are you or are your loved one, or have you or your loved one coughed up sputum in the prior 2 weeks? And you could see here on the top of the graph, the answer is yes, that over half of individuals responded yes to this question. And if you focus on that purple bar, it's people with CF or adults with CF, where 77% of people said yes. And I think that this is a key takeaway that we had come back from, because we thought that there was possibly no sputum that was being produced because people were feeling much healthier. Next slide. And so there were other questions that we asked during the survey, and I'm not going to go over those in detail, but overall, we did see that Trikafta has impacted the amount of sputum and how often sputum is produced by people with CF. But people are still making sputum. It might not be in the clinic space when your respiratory therapist or your doctor is saying, hey, can you make a sputum for me, and handing you a cup, but it is occurring throughout the other 23 and a half hours of the day. And according to the survey, this is sometimes occurring during airway clearance, maybe early morning or exercise. And we also tried to gather how much sputum was being produced by the individuals who were still coughing up sputum. And it was about dime size, which there's not a specific amount of sputum that needs to be done in order to do infection testing. But I will say for the folks on this call here is that dime size is a pretty good size. Next slide. And so coming away with that community voice survey results, we find that there's an opportunity here that sputum may be collected in spaces outside of the clinic. And I mean, everybody on this call knows that there's been a huge shift within medicine in general from the clinic to the home, with the COVID-19 pandemic kind of fast forwarding us to the age of telehealth and telemedicine. And so we find that there's a real opportunity here to see if sputum sample collection at home may be a potential option, both clinically and with research. Next question. Not next question, next slide. I'm already ready for the questions. Okay, no, we'll get to that. So there's a couple of things that you really have to consider when thinking about remote or home sputum collection, which are, making sure that an individual has all the materials that they need to collect a sample successfully, understanding the steps, so being instructed properly. Also the shipping conditions. So if somebody is going to collect something at home, they're going to ship it likely to the laboratory. So in what conditions? Will it require an ice pack? Will it just be shipped to room temperature? And then the ways to ship, for that individual, would it be dropping off the package to a carrier, a mail carrier, or is it scheduling a pickup? And then finally, as opposed to collecting something right in clinic where you're giving it to your care team and for them to send, have it directly to the lab within hours, that shipping would take time, potentially overnight transport. So these are all the things that we have to consider when we're thinking about this for the purposes of both research and for clinical purposes. Next slide. And so home sputum collection is starting to be explored, both in clinic and research. Clinics nationwide, really since the start of the pandemic, have, and some preceding it, have started to utilize sputum cultures collected at home. If you have not experienced this with your personal care team, that's okay. This is not standard of care. The models of care are actually being explored right now. We're trying to see if this is something that can be feasible. And then kind of switching to research, there are research studies that are active right now, some of which that were mentioned during the keynote and also during Luke's talk, including PROMISE, which is looking at people who are on Trikafta and their clinical outcomes in real life. And then also PREDICT in patients, which is a specific research study looking at non-tuberculous mycobacterium, or NTM. And so those studies have now implemented home sputum collection for the purposes of research studies in the era of kind of this telemedicine and also the Trikafta impacting expectoration. And then I'm happy to kind of introduce this pilot study that is trying to look at the feasibility of home sputum collection for the purposes of fungal detection. Next slide. And so the CFF, just as Tiffany outlined really nicely with the Infection Research Initiative, really care about this area of CF, primarily because people with CF and families of people with CF have really asked about this. And so this is part of that commitment, where we have developed a pilot study to investigate if adults with CF can successfully collect a sputum culture or sputum sample at home and send it directly to the laboratory from their home. So it's a pilot study to really inform home sputum collection to detect fungal infections for future clinical trials. And what we're doing here is we're trying to see if sputum samples can be received in a day through this pilot study, what kind of quality that the sputum is that we're receiving, and can we really culture Aspergillus fumigatus, which is one of the most common fungi within people with CF that Luke kind of mentioned in his first talk, in specific people who are likely to have Aspergillus. Next slide. And so this is kind of what our pilot study has been doing, and this is what home sputum collection may look like. So it would be sending the materials to the participant or the person with CF who's producing this sputum, that they would be trained accordingly. So that's step 2, making sure that they fully understand what they need to do or what is needed in order to collect and ship the sample. And then finally shipping the sample, which for this pilot study, we're using FedEx, and we've instructed people who are participating to send a sputum culture once a week on 4 occasions. Next slide. And I'm happy to say that although the study is ongoing, that we've had early success. So there's been only 1 out of the 22 participants who haven't been able to cough up all 4 samples that we have asked them to. So just as the community voice survey has informed us, there are opportunities to get and collect sputum successfully, and we've been able to analyze them in the laboratory. So, I mean, this is really promising news. Next slide. And this is just kind of hitting home, because these are the words directly from the participant, that home sputum collection may be a good option for research and potentially for clinical purposes. And so just to summarize what this individual had said, it said, they say, I found the instructions fairly easy to follow. And as someone who does not cough sputum that much, I was still able to produce sputum samples when needed. So I think that this really speaks to an opportunity here. Next slide. And so some of the people on this call may be thinking about children too. What about children who never coughed up sputum even prior to starting a modulator, or currently just don't cough up? And so there have been investigators who have looked at this, specifically a group in Colorado Children's Hospital led by Edith Semanek, who studied actually home oropharyngeal swab kits for families with children with CF during the pandemic, in which a respiratory therapist would train a family. There would be written instructions, all the supplies that would be provided. And in this study, 33 children participated, and a little bit over half of families submitted and returned the swabs. And I don't know if you could see the figure really well, but the bottom line is 3/4 of the swabs returned actually showed a CF pathogen that was significant. And the thing that I want to highlight here is in the green, there were 5 children who had Pseudomonas in those home collected swabs. And 4 out of those 5 were actually Pseudomonas for the first time. And so some of you may know on this call is that when Pseudomonas is grown for the first time, that the clinical guideline is to try to eradicate, meaning try to treat it with antibiotics to get rid of it. And so this led to an actionable kind of next step that the clinicians provided for these children based on these home swabs. So I think that this is really powerful evidence, and it just shows that there's a lot of promise in this. Next slide. And so this is really just to kind of say that there's more work to be done. Obviously that the landscape is changing. The CF Foundation is responding to that changing landscape in a lot of different ways. One of which is that the Remote Endpoints Task Force, which is specifically looking at a lot of different clinical endpoints in the kind of changing world, with highly effective modulators or Trikafta being available for a lot of people. And like home sputum collection or the changes in sputum production are kind of part of that endpoints task force. So there's a lot of work being done there. The CFF National Resource Centers, which these are resource centers that are specifically designed to help both clinicians and also researchers in industry to kind of understand how we should be testing things and what we should be testing when it comes to CF clinical research. And so this is an opportunity to really tap into that in order to get a better understanding of how we can incorporate remote testing more. And just finally, it's just a summary that researchers, clinicians, and the foundation are really working on how to incorporate these novel ways or home sputum collection into the care of people with CF. And so I believe that that is it for my slides. And so that is really, we're really kind of wrapping up at this time of all the presentations. We hope that you've really enjoyed some of this kind of sharing of what we are passionate about, what we feel like is hot right now in the infection research space. And now we really want to engage you all, because I feel like this is the purpose for ResearchCon, to understand and know the questions that you have about infection research. So this is where the polling is going to be coming in. So just to remind you all that the polling can be found right next to your chat boxes, and it will let you know about when you could go live with this. So this section is, well, we kind of coined it like the choose your own adventure. So it's essentially a poll where we want to know which infection topic that you want to kind of hear about or have us discuss on. And we'll give you choices. There's going to be a total of 3 polling questions, and we could go to the next one, which I will read off, and then Haley will take over. So this is the first question. So which pathogen, AKA bug, do you want to hear more about? And so go right there to your polling section, and you could see all these options and click on the options. So A would be Pseudomonas aeruginosa. B is Staphylococcus aureus, or MRSA. That's really a subtype, as Luke had pointed out. C is Burkholderia cepacia complex. D is non-tuberculous mycobacterium. And E is Aspergillus fumigatus. So please make your selection. And as we're waiting for those polling to kind of go through, I mean, I really think that there's been just a lot of information, I think, given, and a lot of questions that were a lot of questions that were posed even during the talk and comments that were posed during the talk. So let's see if we could have a question here. I'm just trying to look through here. So I think that there's a good amount of questions that are coming through about Trikafta and how Trikafta has impacted thick mucus in the lung and how this affects infections. And actually, this is a question that we're going to be addressing in the future too, as we are waiting for these polls to get through. Wait, it looks like there's answers. Haley, do you want to share the answers? And then we could see whether or not we could go back to that Trikafta question, because it's actually one of our questions for the next polling question.
Sure. Yeah, so with the, we kind of had an almost overwhelming winner here. It was Pseudomonas aeruginosa. So let's see, I forget who's going to speak about that. I think it's Luke. Take it away, Luke.
The winner. So proud of it. I had my money behind this one. Pseudomonas aeruginosa is a very interesting bug. Apologies if you just heard my text message go off. This is probably the best studied of all the bacteria that we isolate from CF samples, and I think it's, as I say in quotes or in parentheses, they're probably the most feared. I think people are particularly worried about getting Pseudomonas, or are worried about the lack of the ability to get rid of it. It's important to point out, by the way, that there are plenty of people who have had Pseudomonas for long periods who have done okay. And of course, there are people all over the map in terms of how they do with Pseudomonas chronic infection. Pseudomonas lives nearly everywhere. It's particularly fond of water and moist surfaces. You can find it in all kinds of water sources in the environment, such as lakes, loves hot tubs for some reason. It lives in our plumbing. It can live on the surfaces of fruits and vegetables. It's very adaptable. And in fact, that's what this bug is particularly known for. It can adapt to lots of environments. It can also adapt to lots of stresses, like antibiotics, for example. And so it can cause lots of infections in people who are susceptible to them, not just in the lungs of people with CF, but urinary tract, bones, skin, eyes, other places as well. And usually it's because somebody has an underlying susceptibility to this particular bug, but the general public can have infections in several parts of their bodies as well, even if they don't have an underlying predisposition. Once upon a time, really in beginning about the 1980s or 90s, this was the most common traditional pathogen isolated from people with CF. First, it was Staphylococcus, and then as penicillins were used to treat Staphylococcus, then Pseudomonas became the most common. And now that we're better at treating or preventing Pseudomonas chronic infection, Pseudomonas has become less common. So that all occurred in the early 2000s after the introduction of inhaled tobramycin. Now fewer than 50% of people in the CF have their cultures positive for Pseudomonas. This is different in different countries. It tends to be intrinsically resistant to a number of antibiotics, which means there are some antibiotics that will never work against any Pseudomonas, but we still have quite a few of them that will work against many Pseudomonas. There are, of course, some multi-resistant Pseudomonas against which we don't have much. And this is one of the reasons why there's such an interest in developing phage therapies against Pseudomonas to try to expand our list of tools that we can use to treat this bug. I think that's all I had on this. Yeah.
Thanks for that, Luke. The only part I would add there too is that many of our industry programs focus on Pseudomonas as the most prominent bug, right? And so you'll see in our overview of our portfolio that a lot of the companies focus on Pseudomonas.
Yeah, and I think I saw we had a relevant question from the pre-submitted questions. So are there any activities or environmental factors that those with CF should be avoiding to help reduce infections?
I'm going to take that question as if it were directed, it were relevant to Pseudomonas in particular, and then I'll talk about whether, because I think that's what most people are asking. I can expand it a little bit at the end of this, but the short answer is the evidence isn't very clear on this point. Once upon a time, the CF Foundation website about Pseudomonas recommended avoiding going swimming, for example, because we know that this is a water bug, and they no longer do that. They no longer strongly suggest you stay away from hot tubs, for example, on the website. You can go to the website now and take a look. There are some places that give a little bit more detail about this. And by the way, this is informed in large part by studies that have looked and people at the whole CF population and looked to see, for those who did develop Pseudomonas infection, who had specific risk factors. Can we predict what activities or environments were more likely to lead to these infections? This has been done in many countries, in the United States, in Australia, where there's a lot of water, by the way, in some places. And nobody's really been able to find really clear predictors, which raises the possibility, and I don't know this is true, but I think some people believe this is a possibility, that the biggest risk factor is just having lungs that are a good environment for Pseudomonas, because we're always exposed to it. That said, I think many physicians who treat people with CF will still recommend staying away from hot tubs, because you can find high concentrations of Pseudomonas in that water. Again, I don't know if that is likely to prevent the acquisition of Pseudomonas because it's so ubiquitous, but there are still some hospitals, such as in the United Kingdom, that advocate for that, recommend that. But the short answer is there isn't much. Really, the best activity I can recommend for avoiding getting infected with any of these organisms is to remove the mucus that traps them and serves as the site for them. So the medicines that you use, definitely. Activities like exercise, which I think is great airway clearance. And I apologize if anybody's out there groaning, because you've heard this over and over again, but that's basically the best thing that I can say is the treatments that make mucus softer, allow it to get cleared out, and the activities that make you cough it out are probably the best. Now, moving on from Pseudomonas in terms of environmental risks, there's some information on non-tuberculous mycobacteria. These types of bugs, and they're much less common than Pseudomonas, but I know that a lot of people think about them. They do seem to be the infections with them seem to be more common in certain parts of the country, particularly in the Southeast, for example. We don't understand why that is, and we don't know what to learn from that, whether there are certain locations or places where you're more likely to be exposed to them. And finally, in terms of MRSA, for example, same story. The rates of MRSA infection in people with CF seem to mirror the rates of MRSA in the general public in certain parts of the country. So there are certain parts of the country where MRSA is just more common among the general public. It colonizes a good fraction of everybody. And so, there just seem to be these variations depending on where you happen to live. And I can't in good conscience recommend that anybody move to avoid these organisms, because I don't think that's going to make anybody better. But one more piece of information I wanted to add. For some of these organisms, particularly Pseudomonas, and for some Burkholderia, and some other organisms, there is some evidence that these bugs can be passed from person to person. And so, most importantly, in terms of the evidence that we have right now, the one activity I would recommend avoiding in order to prevent infection, at least at this point in history, until we understand better, would be activities with other people with CF in which physical contact is involved or close proximity. This is basically just what the CF guidelines recommend. I wish that weren't the case, but following the CFF guidelines in terms of transmission risk, I think is very important.
All right. Okay, so I think due to time, we're going to have to move on to our next poll question here. So the second poll question we have for y'all is, which important infection topic should we dive into deeper? First one, how highly effective modulators like Trikafta may impact infection that Gina kind of touched on earlier. Bacteriophage therapy, Last one, antimicrobial resistance. And again, you can find the poll section on your screen. Should be able to vote for this, and we should have results coming in shortly.
Just as we're waiting for those results to come in, I could just comment a little bit on Aspergillus and that question about kind of practices to prevent infection. So similar to a lot of the bacteria that Luke was mentioning, that Aspergillus, which is a fungus, it's kind of just like a different type of player. These spores are everywhere. So often people ask if there's certain things that they should be avoiding, like areas in their house or, certain regions. But really, there's no clear evidence to support any of those practices to prevent inhaling one of these spores for this to impact your airways. And so, like, similar to what Luke was saying, there's not this like magic bullet practice that you need to be doing. Some individuals, because Aspergillus is and other fungi are in soil, that often, if this is impacting you in a negative way, Aspergillus in particular, that, avoiding, heavy gardening or something to intensify that load that you might be inhaling is something to consider. But in general, care teams do not recommend avoidance of these on a regular basis. Let's see if our polls have come to any conclusions. I think we're still kind of cooking on that, but
so it looks like two topics are right about tied. The first topic, how highly effective modulators may impact infection, and bacteriophage therapy are kind of going back and forth. So I think we should cover, I agree with Tiffany. She posted a chat to us that I think we should cover both if possible.
Yeah, we could be brief, I think. So to talk a little bit about how highly effective modulators like Trikafta are impacting infection is that we have a predecessor here, right? I think Greg Sawicki had talked about how we celebrated the 10 years of ivacaftor, and ivacaftor was first approved for individuals with G551D. And this was a study that was done by Sonia Helchi and others, where they saw that after ivacaftor use in this population, where Pseudomonas was reduced and Aspergillus was reduced when it came to cultures. Now, fast forward to the present, where we have Trikafta, and there's been really smart investigators looking at this next slide. This is ongoing work from the PROMISE study. I think you guys have heard the PROMISE study mentioned several times all throughout this evening, because it's just an amazing study that we're learning a lot from, and how Trikafta is impacting people with CF. And it's showing that Trikafta, which here it's signified as ETI, which is elexacaftor, tezacaftor, ivacaftor, which is the generic name. It's showing that that Trikafta is reducing the CF bacterial abundance. So I know these are really kind of crazy graphs here, but the bottom line that I want to show you is that if you look at the y-axis, which is like the up and down axis, it's the colony forming units. So it's like the amount of bacteria that we're seeing. And then the x-axis on the bottom of the graph is showing like pre-Trikafta 0 months, and then 1, 3, and 6 months where people are sending in their samples or collecting their samples. And we're seeing an overall reduction in staph, Pseudomonas, and Stenotrophomonas, even as early as 1 month after Trikafta. So we, next slide, we are seeing that even after that first culture, people are still remaining repeatedly negative, especially with Stenotrophomonas, which is a bacteria that is also multi-drug resistant, is not as common as Pseudomonas, but definitely can be problematic in some people with CF. So this is really exciting news. This is also very preliminary. This doesn't mean that Trikafta is necessarily eradicating our infections. In fact, Trikafta doesn't have any anti-infective properties. Like, it's not that it's killing the bacteria, but it's allowing that CF protein recovery to occur in order to decrease that environment with that bacteria and other pathogens really like to thrive. And so, there's kind of more work that's being done, but preliminarily, it's really exciting to see that we are seeing changes in CF microbiology with Trikafta. I think that's it for these slides, but is there anything else? Luke is actually involved with some of the work with Promise. I don't know if you have anything to add, Luke, about those slides.
No, I think you summarized it very well. Thank you for listing that. Except to say that the effects that we're seeing, that you've seen in Promise, are really describe what's happening in people who have established infections primarily. And I think they're really, you can divide the question that you asked into how modulators are changing infections in people who already have some lung disease and have had infections for a long time. And that's one thing. The other question, which we haven't answered, and hopefully we will have answered sometime soon, is whether modulators can prevent the development of infections, and then how that relates to preventing lung disease. So that, I would say, we have our fingers crossed. We have good reasons to hope that modulators will have a very profound effect, just like they are in adults. But we hope that they have an even more pronounced effect on completely preventing some of these infections, some of these pathogens in younger people.
Great.
I think you guys nailed it. I don't have anything additional to add other than lots of data being generated this year and early into next year, and we are working on the best way to share that so that everybody is working from the same knowledge base.
So then we should shift to phage. I know a lot of people want to talk about that too. Luke, do you want to take us away with descriptions about phage?
Absolutely. Well, bacteriophage are viruses. It's important to note that they're extremely common in nature. Most bacteria, actually almost every organism on the planet, has a virus that attacks it, and bacteria are no exception. So bacteriophages are viruses that attack bacteria. And bacteria and phages tend to live together. They're found throughout the environment, and there are many different kinds of bacteriophages, but some of them happen to kill their hosts. Some of them do not. So phage therapy is a kind of treatment that leverages these pathogens, bacteriophages, makes use of the fact that they attack bacteria, and in some cases they kill them. And the therapies that are being developed generally involve identifying bacteriophage in samples from the environment or from people, and that we know are going to attack the particular Pseudomonas or MRSA or other organism you have infecting you, sometimes making a cocktail of them, and we'll hear a little bit more about that from Tiffany, to make sure that you have multiple different bacteriophages to attack all of the bacteria that you have, and delivering them through a couple of different ways. Some bacteriophages are given through the IV. Some of them are given topically. So for example, for wounds, sometimes they're just put right on the wound. For CF, it would be inhaled if you want to do it topically. And compared to antibiotics, they have some very attractive advantages. We know, for example, that they are natural, that they work very well. They are very, very focused. Bacteriophages only attack the particular species that they evolved for, that they came from. And in some cases, they're even more precise. They only attack the particular strain they came from, and they don't attack all of the other ones. And we have never in history had such a really precise treatment before. So it wouldn't, in theory, have much of an effect on the other bacteria in other places, like in our guts. And so people are working very avidly in trying to develop bacteriophage therapy for people with CF. Tiffany, I'm sure you have more than that. Yeah.
No, that's great, Luke. What I would add, just in the interest of time, is that the foundation has invested heavily in phage, and I think part of our assessment is that we are moving more from an observational and a compassionate use to more controlled trials where we can see how phage can apply to more than just kind of one-off patients. So that's really exciting. But what you see here are all the companies that we have invested in terms of a phage perspective. And I'm happy to announce that Felix is one of our newer companies that we have just invested in this year. But, our overall goal is really to interrogate the science behind phage. As Luke said, there's lots of different strategies, whether it's a cocktail or engineered phage or, kind of stratifying or pre-selecting before you actually dose. But again, our role is to really look at all of them and give patients with CF the best shot at either participating in these studies and overall giving patients on a whole, right, the opportunity to be treated on a larger scale and not just individual studies. So we're excited and we hope to have more news to share about many of the studies that are in clinical development later this year as they're underway.
All right, I think with that, we should move on to the last poll question. So the last poll question we have for y'all is, which of the previously discussed topics do you want to hear more about? A, drug pipeline for new anti-infectives. B, novel biomarkers or tests to detect infection. And C, remote sputum collection or other remote activities for infection research. And then I think while we're waiting for poll answers to come in, there was one question about sputum. I think one of y'all had mentioned that CF patients were producing less sputum even before modulators came on the scene. Do you guys have any reasons why that might be the case?
Yeah, I'm the guilty one. I'm the one who said it, so I'm happy to take that one. Yeah, that observation's been made progressively since, well, for over a decade now, that the proportion of visits, clinical care visits for people of different ages, where the sample taken from patients at different ages is a sputum sample compared to a swab, has really changed. So there have been fewer and fewer sputum sample, and that's where these data come from. That's where that came from. Why I said that, rather than asking people. And I think a lot of people feel that we've done in general, we've done a better job at choosing treatments that make people better. And it may have been antibiotics. I think that antibiotics have changed, but so have our mucolytics, which is really pulmozyme, hypertonic saline. Any one of those could have helped. Of course, we should point out that patients are the ones who are taking care of themselves. So, of course, they deserve the enormous burden of the credit there. But I guess the short answer is we're not totally sure. This was happening even before ivacaftor was approved, but it probably has something to do with changes in treatment and just better therapies.
Cool. All right. So with that, we do have the last winner for this poll question. Pretty overwhelming, was drug pipeline for new anti-infectives.
So what can I say about this other than that we are really dedicated to diversifying our portfolio and making sure that we're pulling in projects that can offer benefit to patients sooner rather than later. So that's why we were happy to announce some of our later stage assets with Arivus and Specis at the end of last year. I think overall there's a lot we can say about our portfolio, but I think the biggest thing that I would say is that there's a lot of promise and there's a lot of attention on infection right now, just based on coming off of the pandemic. So I think, one takeaway here is that this is not our space to fight alone. Infection is a big deal for the whole world, if you will. So, all of our efforts around antimicrobial resistance and, working with lawmakers regarding the Pasteur Act and other processes around drug development for antimicrobial development is also going to be important as we advance our pipeline. Anything Gina and Luke, you guys want to add about any of these programs that may be exciting to you? Love to hear that as well.
The only things that I would add is that just like looking at the breadth of kind of where it is, like when you talk about Caliber, which is like looking at where the kind of CFF is investing in a company that's just looking at novel molecules to fight Burkholderia cepacia complex. So kind of that phase versus looking at, like with the gallium citrate, like looking at this in human subjects at this point. I think it just shows the breadth of what's going on. Of course, I'm a little bit biased here because I'm also very interested in the fungal space. So that really with Pulmicide, which is something that the Infection Research Initiative is committed to, is looking at an inhaled novel antifungal compound in individuals with CF who've underwent lung transplantation. So it's involving this population that still is dealing with infections, this population that still matters to the CF community, and trying to examine how whether or not that this is efficacious in this population for combating fungal infections. So it's just, I think that it's worthwhile highlighting how just the depth and the breadth of what is committed when it comes to novel anti-infectives. So that's just all I got to say about that. Luke, anything else to add?
No, I feel exactly the same way. Maybe because I'm a bacteriologist, I might favor the bacteria over the fungi, but I appreciate your opinion. I think I would add though, I'm excited about everything, about all of these, because there are different, there are different reasons why I'm excited about each one of them. For example, as I mentioned, for the phage, having a natural, non-synthetic antimicrobial available that's really precise, that doesn't have a lot of collateral damage, that you can identify and maybe produce in a really personalized way, or in a way that's responsive to changes. I think that's very exciting. Although I think we're all holding our breath about just how well they'll work. I'm very excited and I'm hopeful. That said, there are a couple of candidate therapies that are on this list that I'm really intrigued by because of their breadth. For the opposite reason, they're not specific. Like gallium citrate, for example, I find really exciting because it has the potential to treat so many potential pathogens. And again, it's not an antibiotic, which means it's unlikely that resistance against classical antibiotics is going to affect the efficacy of this particular drug. So I'm very fond of, as Gina was saying, excited by the breadth of all of this, at the creativity that it really highlights, because I think somebody asked a question that I saw on the previously submitted questions about whether there are new antibiotics. The short answer is there haven't been really new ideas thrown out there for antimicrobials for years. And here are some completely novel ideas on this list. I find that very exciting, particularly because it's for the population that I take care of the most as a physician.
Yeah, and I would just wrap up, Luke, that I think what's so amazing about being here at the foundation is that we're following the science and we're following the policy that will ultimately help us change the space and make antibiotics attractive to work on. So I just want to thank everyone in the steering committee, right, and everyone who does research on behalf of infection in this space. And we're heading for an exciting 2022, and happy that Luke and Gina are leading some of our great work streams that we'll be sharing with the community this year.
All right. Thank you all so much for joining us today. And thank you to our speakers for sharing your knowledge and insight about infections, infection detection, diagnosis, and upcoming research. There are many wonderful resources related to this discussion in the resources document found on the reception page. For this session, you'll find the slides we shared and other items that the speakers thought you might find valuable. Please spend some time exploring the resources and download anything you want to keep. We now have expo booths and networking sessions open for the next 45 minutes. In the expo, you can visit CF Foundation staff to learn about several foundation research initiatives, or visit one of the two main speaker booths where you can casually interact with Dr. Greg Sawicki and Shelby Lubert from the opening keynote, or Dr. Jay Freeman and Amanda Hively from the GI session, Listen to Your Gut. If you're more interested in, if you're more interested in meeting other ResearchCon attendees, visit the networking tab, which is a fun feature that allows you to connect with others and get randomly matched with another attendee for a 5-minute video conversation. This attendee could be a clinician, CF community member, researcher, or CF Foundation staff member. You never know who you'll get matched with. After the networking and expo booths, we hope to see you at 12:45 p.m. Eastern Standard Time on Saturday, April 9th for day 2 of ResearchCon. Thanks again for coming to learn about infections.